Hello everybody, my name is Nico Pijls. I'm a cardiologist from the Catharina Hospital in Eindhoven in the Netherlands, and it is my pleasure to give this presentation about fractional flow reserve and to show you how it can be used in the cath lab and improve your practice. I will tell you something about landmark evidence in the evolution of fractional flow reserve, the ease of use, cost effectiveness, and the importance of FFR in daily practice. At first, you should realize that the concept of fractional flow reserve is based upon the following two principles. In the first place, we have to realize that it is not a resting blood flow, but maximum achievable blood flow which determines the functional capacity of a patient. Patients with angina pectoris do not complain about resting blood flow, but as soon as blood flow is not sufficient anymore to cover the demand, then they will get angina. The second point is that at maximum vasodilation, corresponding with maximum hyperemia or maximum exercise, blood flow to the myocardium is linearly proportional to myocardial perfusion pressure. To understand that, have a look at this slide. In the upper part, you see a normal coronary circulation with on the left hand the coronary artery and then the myocardial vascular bed. In this case, the perfusion pressure across the myocardium is 100 mm mercury. In the lower part of the slide, you see a stenosis. To realize the hemodynamic effect of that stenosis, you should realize that it is not a gradient which is important, but the fact that the perfusion pressure has decreased to 70 mm mercury only due to that stenosis. And because of the linearity between pressure and blood flow at maximum vasodilation, that means that the maximum blood flow in the lower part is only 70% of what it should be in the upper part. So in fact, the ratio of maximum blood flows is represented by the ratio of pressures. In the upper part, the perfusion pressure is 100 mm mercury, in the lower part 70, so maximum blood flow achievable in the stenotic situation is only 70% of what it should be. And that is exactly what we mean by fractional flow reserve. In fact, it is that very fraction of maximum achievable blood flow which is still there despite the presence of a stenosis. Let's have a closer look now at FFR and let's see what are the prerequisites for a reliable index for decision making in a cath lab. In the first place, as a matter of fact, it should have a sound scientific basis and a good experimental validation. That has been done for FFR extensively. All basic features of FFR have been thoroughly validated experimentally and clinically over more than 20 years. Between 1993 and 2006, there were 5 original papers in circulation on animal studies in dogs and swine, and thereafter 64 original papers have been published in the New England Journal, Circulation and JECC in humans. And altogether there are more than 2,000 publications in PubMed validating the features of fractional flow reserve. The next prerequisite, of course, is that an index should be accurate. Accurate means there should be a clear cutoff value to distinguish between the healthy and the pathologic situation with a narrow gray zone. And that has been done for fractional flow reserve. What we know is that if the FFR is below 0.75, you can be 100% sure that your stenosis is causing reversible ischemia if the heart is stressed sufficiently. On the other hand, if FFR is above 0.80, the chance that such a stenosis will give in ischemia is less than 5%. So altogether you can say above 0.80, no ischemia, below 0.75, there is ischemia. You can wonder why FFR became the gold standard, and I would like to go into detail in that a little bit more. In general, if you have any index to be used in humans for decision making and you like to validate a cutoff value, you have to do that in 2 steps. In the first place, you have to search where the threshold should be about. You have to search a threshold value in a selected population. And secondly, you have to validate that prospectively. Let's explain me that a little bit further. In the first step, you have to look for patients who definitely have ischemia or who definitely do not have. For that reason, we took a population of patients with single vessel disease, a tight stenosis in one of the arteries, a positive exercise test and chest pain. These are the patients of whom you can be sure that they have angina pectoris. In these patients, we did a PCI. We repeated all the tests after the PCI. And if the patients do not have complaints then anymore, and if the exercise test turned to normal, you know that there is no ischemia anymore. And these are the results for that first step of the study. You see the red points on the left hand, which are the ischemic values, the green points, which are for sure non-ischemic values. And if you see that, you already suspect that there must be a threshold somewhere in the range 0.75, 0.80. In this study, it was 0.77. So far, that has been done for many other indexes. But once you have done that, you can make an ROC, but that doesn't say so much because it is retrospectively in a selected population. So the next step should be to do a prospective validation, and that has only been done for FFR. And how do you do that if there is no actual gold standard? Well, we did that study as follows. We created a gold standard by what is called a prospective, multi-testing, sequential Bayesian approach. Sounds quite difficult. It is a test where you use the following principles. If you do an exercise test, you are looking for an electrical index of ischemia. If you do a MIBI-SPECT, you are looking for a perfusion index of ischemia. And if you do a stress echo, you are looking for a contractile index of ischemia. These three are independent. That means that if the exercise test has a limited accuracy, let's say 75%, if the MIBI has an accuracy of, let's say, 80%, and the stress echo also of 80%, the combined chance that all these three tests will give you wrong results is given by the equation in the bottom of this slide, and that accuracy of the FFR calculated in that way is more than 99%. So what you do is performing all these three tests in a very short period of time, less than 24 hours. If one of these tests is positive and returns to negative after the intervention, you know for sure that it was true positive before and true negative thereafter. And if all the tests are done exhaustively without being positive, you can be rather sure that indeed the patient has no ischemia. So this is a rather complex way of testing, very intensive I would say, but the only accurate way to prove prospectively what is accuracy. And if you do that, you find that the accuracy of FFR is 99%. In this type of testing, every now and then, you might have a patient who is not classifiable. That is the case if the patient has one or more positive tests, but no intervention performed. What we did in these patients was taking the worst case scenario for FFR, and even if you do that, you find an accuracy of 93%. So what we know is that FFR below 0.75 means ischemia and justifies an intervention if that is technically possible. If your FFR is higher than 0.80, you do not have to place a stent, you know that there is no ischemia. And FFR is the only functional index which has ever been validated in such a thorough way, and therefore you can consider it as a gold standard. And this has been confirmed in many other studies thereafter, in all possible clinical situations, in diabetes, in previous infarctions, after bypass surgery, etc. A next feature of a good index should be that it is reproducible. These are the reproducibility data for Fractional Flow Reserve in the recently published VERIFY study in more than 200 patients. And what you see is that this reproducibility is excellent. More generally, if you look at any index and every cutoff value, irrespective how accurate it is and how small the variability, you should realize that if you are very close to the cutoff value and you repeat the test, it might switch over from one side of the cutoff value to the other one. But that has nothing to do with a particular index, but is a statistical phenomenon. And if you do that for Fractional Flow Reserve, you get a curve like this, and you see that the gray zone in the bottom is corresponding exactly to 0.75 to 0.80. And only in the area between that, you might have to switch at a reproducible measurement from one side of the cutoff to the other. So this is a very nice result in fact. And if you compare the coefficient of variation of Fractional Flow Reserve to other commonly used indexes, you see that FFR is rather unique among other clinical indexes we use in normal hospitals. And if you compare by the way, fractional flow reserve, it is the green curve, to resting indexes. One of them is given here, IFR. You see that if you do a misclassification of FFR of 5%, if you find that acceptable, you have this very small gray zone. And if you would like to have a similar gray zone for these resting indexes, at least 40% of your data would be misqualified. You can also look to it in another way. If you look at this complete collection of data and you are talking about reproducibility, only 2 times 2.4% of the patients, 2.4 is the coefficient of variation, are within that small green box. And if you check that in a very large clinical series, here 1200 consecutive patients in whom Duplo measurements of FFR were performed, you can see that there was not any crossover from red to green or vice versa. A few patients went from green to gray or from red to gray, but there is no crossover across the gray zone. So again, the reproducibility of FFR is extremely high and the measurements are very reliable. A next prerequisite is that an index should be easy to perform. Well, there is little discussion about that for FFR. These are the data for the FAME study, and you see there that in a group with 2 or 3 vessel disease, the total procedural time without FFR was 70 minutes. The total procedural time with FFR was 71 minutes. So using FFR and 2 or 3 arteries did hardly prolong the procedure. The last thing which is important is that an index should predict outcome. You can use an index as nice as it looks like, but if it doesn't influence the outcome, why should you use it? For fractional flow reserve, it has been demonstrated repeatedly that it has of influence on outcome. This is a slide showing a study from Aalst, where FFR was used in proximal LAD stenosis, and you see very clearly that those patients who had a high fractional flow reserve had a much better outcome than those with a low fractional flow reserve. The follow-up in this study was 5 years. And if you look at the FAME study, in the FAME study you found that all types of events, death, mortality, target vessel revascularization, are all decreased by 30 to 35% when you are using fractional flow reserve instead of only standard angiography. So indeed, measuring FFR is important. It really does reduce events. It improves outcome. And in the FAME2 study, which has been published more recently, there were 3 groups of patients. Patients without ischemia, which were treated medically. That is the green plot here. There were patients who had ischemia and were treated medically. The red one, you see that if there is ischemia, outcome is much worse. The cumulative incidence of events is much higher, 5 or 6 times higher. But when you treat these patients by stenting, guided by fractional flow reserve, you go to the blue line and you bring the risk of these patients back to the risk of patients without ischemia. It is said in the FAME2 study that the endpoint consisted of death, MI, and urgent revascularization. And the blame was that urgent revascularization was a man-made event. But if you look at these patients and you only take those who had enzyme elevations, myocardial infarctions, or evidence of ECG or evidence of ischemia on the ECG, and you leave out the other ones, even then you find that there is a significant advantage in primary endpoint when you look at the patients treated by FFR-guided PCI versus the OMT patients. And if you look at it from another way, with the so-called landmark analysis, you get even, let's say, a more striking result. In the landmark analysis, the events in the early phase of the follow-up are left out because you know that any intervention is accompanied by some event rate. If you go then counting from 7 days on, you see that the curves are coming apart, even when you only look at death and MI. And then at a particular point, you see that the difference becomes significant, 0.05, and that was the very moment when the safety board of the study decided that the study had to be stopped because patients not treated by FFR-guided PCI were at a significantly higher risk. A few final issues. First of them is the hyperemic pressure pullback recording. In this slide, you see on the left-hand side 3 anatomical situations, one very tight lesion, one diffusely diseased vessel with a couple of superimposed lesions, and on the lower part, very diffuse disease. All these patients will have ischemia on the stress test, and they will all have a defect in the inferior wall on the MIBI-SPECT. But if you do the pressure recording, you can very nicely find out where the hemodynamic problem is originating. In the upper part, you see such a very sudden step up. That's not surprising, of course, if you look at the angio. In the second part, you can see that there are 2 step-ups. So you know that by stenting this patient in these 2 spots, you are doing a good job for him. You can relieve the ischemia, you can help the patient. But in the third one, you see that the pressure decline is very gradual, and you know that you cannot help this patient by stenting. You know that the patient has ischemia, but fundamentally you cannot help him by stenting. And this type of information about spatial resolution of disease is not obtainable by any other index. A second point which I would like to stress is the question if it is always necessary to induce hyperemia. As you know, the recent years show that use of a kind of resting index, let's call it FFR light, different indexes, PDPA at rest, or diastolic PDPA, IFR, IIFR, and all these resting indexes have in common that they try to avoid hyperemia, that they are not independently validated, only versus FFR, that they only have a moderate accuracy, 70 to 80% compared to FFR, and that they are based upon questionable underlying scientific assumptions. And to demonstrate that that's insufficient, I would like to show you this slide, giving the Poiseuille equation and indicating that the relation between pressure and flow contains a linear and a quadratic component. The linear component being friction, the quadratic component being separation. And as you understand that if in a stenosis the friction is the predominant factor, like is often the case in long, mild lesions, you will have a gradient at rest which only mildly increases at hyperemia. That is in the left-hand side. If you have a short tight stenosis with a high separation coefficient, you might have very small resting gradients which can tremendously increase at hyperemia. So this illustrates that the relation between resting gradient and hyperemic gradient is very weak. And the other point which is important to realize in this context, apart from all other arguments, is that in fact resting conditions in a cath lab are very hard to obtain. You never know if a resting condition is present. There are large fluctuations in what we call resting. And in fact, the only condition which you can reliably achieve in a cath lab is maximum hyperemia. I would like to give you an example of that. A patient with a long, moderate LAD stenosis. As you will agree, it is an indication to measure FFR. Here, the pressure wire is at the tip of the guiding catheter and the equalization is performed. Look at the time, it is 7 minutes before 2. Then the pressure wire is put across the stenosis. We are 1 minute later. This is then what you would call resting pressures. By the way, the patient is asleep. The patient was sedated beforehand, so he was asleep on the table. But 1 minute later, you see that the patient opens his eyes, and immediately you see that the resting indexes, whatever it might be, is changing. That's obviously the case because heart rate and blood pressure are increasing. 2 minutes later, I tell the patient that we will start the use of adenosine. I tell him that this will give some chest pain. The patient is afraid a little bit, and immediately you see that the gradient is further increasing, and the resting index, what it might be, is further decreasing. And then I push up the pressure wire a little bit and put it back again, and you see again the influence on the so-called resting gradient. Finally, we give adenosine, we create hyperemia, we find that fractional flow reserve is 0.69, that is 1 minute later again, and if you wouldn't believe me that there hadn't been drift, well, we pulled back the wire, you see that here, to validate that no drift occurred. So in this patient, we had different types of what you could call resting, with completely different values of IFR or PDPA at rest, and nobody can tell you which value you should rely upon. The only reliable value, reproducible, is the fractional flow reserve. And in fact, obtaining true resting conditions in a cath lab in a conscious patient is an illusion, and by far more difficult and less reproducible than maximum hyperemia. And this also explains a little bit why for these resting indexes such a wide variety of cutoff values have been proposed, ranging from 0.83 to 0.93 and changing every 2 months. There has been a very large study systematically comparing resting and hyperemic indexes. The resting indexes used were IFR and PDPA at rest. What you see is a very large scatter when you compare it to fractional flow reserve. These are more than 1,700 patients. The accuracy of these resting indexes is identical, whatever resting index you are using, and the correlation with FFR is rather poor. Here you see the ROC curves, which are almost superimposed for IFR and resting PDPA. So if we talk about hyperemia, we can say, of course, as a matter of fact, that if PDPA at rest or a comparable index is less than 0.80, as a matter of fact, FFR, hyperemia, will also be less than 0.80, and the hyperemia in itself is not strictly mandatory to decide upon inducible ischemia. But you should realize that without hyperemia, you cannot make a meaningful pullback recording, and you are losing a lot of valuable information. And without hyperemia and FFR, you cannot judge about how much a patient improved by stenting. You do not know where the patient came from. If your FFR went up to 0.91, it makes a lot of difference whether the patient came from 78 or from 65. And finally, avoiding hyperemia is prohibitive for stent evaluation. After stenting, in many patients, no resting conditions are present anymore. There is a kind of semi-hyperemic or half-hyperemic status with a lot of inter-individual variation, and it often takes more than 30 minutes to obtain baseline again. And as a consequence, the resting PDPA and IFR after stenting are often lower than before stenting. We call that a kind of paradoxical deterioration of resting indexes. To evaluate improvement by stenting, you need to have hyperemia too. And although, in summary, it is commendable that people try to avoid hyperemia, you shouldn't do that at the sacrifice of accuracy. If we look back in history, formerly we had to use angiography or QCA, and we knew that the accuracy was 70%. We made mistakes in 30% of our patients. Then we developed FFR. We increased accuracy to 95%. I think that is almost the highest number you can achieve. 100% doesn't exist. And no, because we like to leave out hyperemia, we would be prone to go back to 80% accuracy. Taking wrong decisions in 20%, I do not believe that that really makes sense. We shouldn't like to do that. And is hyperemia so difficult? I don't think so either. It is all a matter of logistics, a matter of education. In our lab, we have these prepared bags, 200 milligram is 100 milliliter. We have a pump with a sign on the side which only says the body weight of the patient, and then you know how to set the pump. This is the situation in the cath lab, the adenosine, the pump, and here the radi analyzer, and you are very easy to go. You do not have to do any preparation in the lab, no difficult calculations, no risk of dosage error, and no loss of time. So hyperemia isn't difficult. In fact, it is easier to create hyperemia than to create resting conditions, but you have to set up a good logistics and to prepare your nurses to educate them. There is another new hyperemic drug called reganodazole. We are doing a very large study at the moment. In fact, we just finished it, and that will be published soon, and that gives even more options for hyperemia. So, in conclusions, I would like to say that both in the diagnostic and the interventional assessment of coronary disease, fractional flow reserve plays a pivotal role. It is easy to perform, is well validated, reproducible, cost-effective, and it has an unequaled spatial resolution. It is related to improved outcome in a number of randomized controlled trials. The most well-known of them are the FIR, FAME, and FAME2. The use of hyperemia remains mandatory to maintain the high accuracy, and there are promising data from new hyperemic stimuli for simplifying maximum hyperemia. Thank you for your attention. It was a pleasure to give this presentation. And as my last slide, my concluding slide, I would like to show you this table, the guidelines from the European Society, which says that fractional flow reserve now is a class 1A level indication to be used in the cath lab. Thank you for your attention again, and I hope that my presentation will be helpful for you to start up or to improve the FFR practice in your cath lab.